Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Today should be a really interesting and fun session. The title of the talk is The Case for Geriatricizing Subspecialty Care. As we all know, the population is aging, as are all of us. And there are not enough geriatricians to do the things that we know geriatricians are incredibly effective at doing. And so I think our institution has been a leader in trying to think that through, and what can geriatrics add, but also what can specialists and primary care doctors do that is appropriate for patients who are older. And so today we'll hear from two of our experts in thinking about how to answer that question. And it's clear that the answer can't just be more geriatricians, but how do we bring geriatrics expertise and sort of their specialized knowledge, skills, and also attitudes to the rest of medicine. And so our two speakers are two experts in this. One is Mike Harper, who is professor of medicine in the Division of Geriatrics. Mike has a clinical practice at both the VA and here at UCSF Health. He attends on the Mobile Acute Care for the Elder Service and supervises fellows in the Community Living Center, and their geriatrics clinic at the VA also practices in our Care at Home program here as well. Mike is a member of the DeBoss Academy of Medical Educators. He is the chair of the board of directors of the American Geriatric Society, and really a national leader in the field of geriatrics. Mike went to Ursinus College, Rutgers Medicine, Hopkins for his residency in geriatrics fellowship, and we were lucky to recruit him to our faculty, and he's been here for quite a while. He will be joined by Leah Witt. Leah is associate professor in two divisions, the Division of Pulmonary Critical Care and Allergy and Sleep here at UCSF Health, and our geriatrics division. She comes by that honestly, in that she is certified and trained in both geriatrics and pulmonary medicine. She tells me she's one of 2 or 3 people in the country who had that Venn diagram in terms of their training. Leah went to Northwestern undergraduate, University of Minnesota Medical School, her residency and pulmonary fellowship at Chicago, and then came here for her geriatrics fellowship and has then joined our faculty. She's really been a national leader in this idea of geriatricizing specialty care. She is one of the coaches for our Pulmonary Critical Care Fellowship. She's also a member of the Academy of Medical Educators. And so really interested in hearing what they both have to say about this. And I think Mike is going to lead us off.
Thanks, Bob. I appreciate it. And you've actually done some of the heavy lifting for me in terms of the things that are the case I'm going to make today. I'm going to start by talking about this word geriatricize. It's a completely made up word. You won't find it in Webster's dictionary. It sounds like a potential hostile takeover. It is not. It is really a word that is fairly familiar in geriatric circles. And it really is, in this case, this really means thinking about ways to partner together, and to think about how to embed some of the principles of geriatrics into the care that we all provide. So Lee and I have no financial disclosures, but we do have one very strong bias that we want to admit, which is that we really do love caring for old people. It is something that I think both of us feel we were very much drawn to in our training, and this is something that we feel passionate about, and hope that we can convey that sense to you today. So these are our objectives. I won't read through them, but I will hope that as much as you take away in terms of potential knowledge, that you take away a feeling today. And that feeling is that this is something we all have to do together. This really requires teamwork in the broadest sense, from communicating with one another, from thinking really holistically about our patients, and that maybe some of you will even be inspired to want to think about ways that you can collaborate with us. Okay, so this is some of the work that Bob's done for me already. This is the obligatory slide that has to be in every geriatrics talk. I try not to ever use this slide, but in this case, it really is part of the argument. And that is that we do have a rapidly aging population. And we think about sort of geriatrics starting at age 65, and that's really the relic of it being attached to Medicare, right? And that's when you become eligible for for Medicare when you turn age 65. However, really, the geriatrics issues really began much later in life, typically 75 and older. But a lot of the data you'll see is related to this age group. So what you can see is that currently, or in 2019, about 16% of the population was over the age of 65. That's going to increase to 21.6 by 2040. But really at the bottom is really the key in many ways, which is the oldest old are the most rapidly increasing part of our population. They're going to double, more than double, from over 6 million to over 14 million from 2019 to 2040. So those of you particularly early in your careers, these are the folks you are going to be seeing in your practice. But this only tells you about a number. This tells you the number of folks. But what do these folks look like? What do we know about this population? So we know that there are lots of chronic conditions that become more common as we get older. And these are data from the CDC. These are the 10 most common chronic conditions for adults over the age of 65. And you can see these are all things that you are all seeing in your primary and or specialty practices. So lots of high blood pressure, heart disease, chronic kidney disease. And then I want to point out just over here that 1 in 10 of the folks you're going to see in this age group probably has some form of cognitive impairment or dementia. And as you get into the 85 and up group, that may reach 30 to 50% of your population. So if you're not aware of that, it makes it hard to figure out how to create a care plan. And we'll talk more about that. Okay. So most of our patients, most of us were trained with a sort of a disease-based model. You learn about how to disease, the symptoms, how to work it up, and then how to treat it. Most of our patients are not going to come to you with just one problem. So this is just showing you, this is data from 2018, looking at folks over the age of 60. And you can see that almost 80% have 2 or more chronic conditions. And more than 1 in 10 have 5 or more. And again, this is starting at the population 60 and over. Again, as you think about the older group, the folks that we typically think of more geriatrics age, this number is going to go up. So it's hard to think about these folks if you're thinking about them just sort of in the silo of that one condition that you might be seeing them for. Okay. So where do these folks get their care? So this is from also CDC data this is old data, but I want to just draw your attention to the right-hand side of this slide. So what you can see here is in 1978, the dark blue, about 60% or more of outpatient physician visits were in primary care, and about the rest were in either surgical or medical specialty practice. Leap ahead 30 years, and that's sort of flipping. So most outpatient visits are being done by medicine and surgical specialists, not in primary care. So, for example, you might be seeing someone in your practice, you might see them many more times than a primary care physician might see them. And you might actually find yourself actually having to practice some of the primary care because of the frequency with which you see folks. All right, so that's the first part. So it's an older population and it's more medically complex. The second argument is sort of the workforce. So this is the total number of board certified geriatricians in the country as of last year, 6,671. That's been a pretty steady number for about the last decade. So we're not a growing field. We're not a particularly declining field either. This represents about 1 geriatrician for every 10,000 folks over the age of 65 and about 3 for every 10,000 over the age of 75. Okay, so if you're in this room thinking, I might need a geriatrician one day, good luck. Because you're going to have to live in a particular part of the country in a particular place to find that person. Okay, so how many geriatricians do we really need? So this is in a paper from 2003. This was a quote. It was projected in 1978 that we would need 8,000 geriatricians by 1990. So we clearly never got to that point yet. So there have been other slogans, 25,000 by 2025, 30,000 by 2030. There will never be enough geriatricians to provide all of the primary care for folks who really need that care, okay? So in order to do that, we need to think more broadly. So just to give you a little bit more, just a comparison. So like, okay, there's 6,000 or 7,000 geriatricians. What about the rest of medical specialties? So there's about 15,000 medical oncologists, 16,000 pulmonologists, nearly 29,000 cardiologists, and 30,000 orthopedic surgeons. Okay, so probably a lot easier to get in to see an orthopedic surgeon than it is to see a geriatrician. Okay, the reason this is important, I'll give you my example. My mother is 90 years old, lives in New Jersey. She's got chronic AFib and heart failure. She sees her cardiologist probably 6 or 7 times a year. She's seen her primary care physician once in the last year. So if that cardiologist is not thinking about her in terms of all of the other medical conditions, she's probably not getting really adequate sort of addressing of those other issues that she has. Okay. So this is a slide that I wanted to share with you. So in 1988, geriatrics became an ABMS medical specialty. In 1994, it was already recognized that we are going to need more help. And so the American Geriatric Society started something called the Geriatrics for Specialists Initiative. And it was really an opportunity to sort of partner with, and this was mostly at the time, surgical and related specialties, to say we need to develop sort of clinical expertise, we need to develop a research base in these disciplines so that we can develop or sort of help to support people who have an interest in this area who are not geriatricians. And so over the years now, we have, I think it's 12 or so different organizations or disciplines that are part of this, and I think 14 different organizations. And more recently, there's also a medical specialties section that's part of AGS that's also part of this initiative. So a big part of our meeting now, if you go to the AGS national meeting, you'll see lots of presentations by folks representing these organizations and sharing the work that they're doing in aging, both clinical care and research. So what's the impact of this program been so far? There's been lots, but I want to highlight 3. The first is grants for early medical surgical specialists, translation to aging research called the GEMSTAR program. This was initially started out as an award called the Janigan Award, and it was foundation supported. But through the GSI and working with the NIA, they were able to convert this into sort of a career development award at NIA. So in 2011, that program started. Since then, there have been over 230 GEMSTARs. UCSF has had 16 of them. So really a disproportionate number considering the total number of awards that have been given. And these are folks that many of you may know in representing nephrology, hospital medicine, neurology, OBGYN, urology, for example. So lots of folks who are doing really innovative and important things in their particular discipline, but focused on aging. The second one is the American College of Surgeons Geriatric Surgery Verification Program. So this began in, I think, 2019. And again, a direct offshoot of the GSI program where they created 30 standards. And now there are about 15 programs that have surgical verification, geriatric surgical verification across the country, and meeting those, to certain degrees, meeting those standards. And they're much more in the process of developing that or engaging in that process of becoming accredited or verified. And then lastly is the American College of Emergency Physicians, who in 2018 started an accreditation program for geriatric emergency departments. There are now over 400 of those, and we have 2 of them here in San Francisco, one right here at UCSF and then one at the VA. And again, these are creating programs that are designed specifically for embedding the discipline of emergency medicine and thinking about the principles of geriatrics care to provide better overall care for folks. That brings me to the age-friendly health system, which I imagine most of you are at least somewhat familiar with now. Again, this is not very old. This program began in 2017 through the Institute for Healthcare Improvement and a very generous grant from the John A. Hartford Foundation, which, if you're not familiar with the John A. Hartford Foundation, they have been supporting geriatrics care since the 1990s, a lot initially in workforce development. I'm here today because of support from the Hartford Foundation early in my career. And I'm going to read this because I think it's important. This was the goal of the system. It's to bring the fundamentals of geriatric practice to every single patient in every single care setting, in every single clinical encounter between an older adult and a care provider. Notice it doesn't say between an older adult and a geriatrics health professional. It says between every provider. And so this was really a way to not just sort of layer on aging care, but to really rethink the way we deliver care. And it's based around this 4M framework of what matters: medication, mentation, and mobility. And I'm just going to briefly introduce them. Leah's going to talk more about them for her part of the presentation. But in my view, it really starts with this top one, what matters. It really requires us, when we are meeting with patients, to really understand what their goals of care are. And oftentimes when we think of goals of care, we're often thinking about sort of end-of-life care, particularly in the hospital. But goals of care really is, we need to think about it more broadly. What is it that matters to them? You know, when I go to the doctor, I have a particular idea. Typically, it's for me, it might be to, you know, I have a respiratory infection, give me something to get rid of my respiratory infection. People living with chronic illnesses, that's not the goal. The goals are going to be different. It may be, you know, I want to improve my physical function. I want to make sure that I can live long enough to get to my granddaughter's wedding. It could be, I just really want you to focus on my symptoms. I'm not really interested in any further diagnostic care. I find that too burdensome. If we don't ask those questions, we don't really know the answer, and we can't really create a care plan that meets those goals. The second is medications. I was taught, if someone comes in with a new symptom, the first three things to think about are medications, medications, medications. So polypharmacy, potential for drug interactions. Are they on potentially inappropriate medications that you can look at through something called the Beers list? Mentation is looking, understanding, identifying, to some extent, trying to prevent things like delirium, depression, and particularly dementia that I mentioned earlier. And then finally, mobility, which you can also think about as really physical function. How is a person moving around in their environment? And are they able to do their activities of daily living and instrumental activities of daily living? So that's the framework around which the 4Ms, or the age-friendly hospital, is designed. I show this slide because in geriatrics, we think there's one additional M, which is this idea of multi-complexity. And I've alluded to this earlier when I talked to you about the multiple chronic conditions. And I love this slide because if you see the center of it, it says 5 M's of geriatric GI care. So this was developed by a group that's really thinking about how to create an age-friendly pathway for folks living with IBD and cirrhosis. And they include this multi-complexity component. This is this idea that patients are coming to you, in all likelihood, are older patients, not just with IBD or not just with cirrhosis. They probably have high blood pressure and osteoarthritis and some other condition. And thinking about that problem that you're faced with in the context of all those other things. Maybe they have difficulty with transportation because of their mobility issues. Maybe they have financial constraints. So understanding that really becomes important. And I want to illustrate that with 2 slides here. So this is one of my favorite geriatrics papers, done by a woman by the name of Cynthia Boyd at Hopkins. And it talks about, it's called the Clinical Practice Guidelines and Quality of Care for Older Patients with Multiple Comorbid Diseases. And it takes, what she did was she took a hypothetical patient, 79-year-old woman living with hypertension, diabetes, osteoporosis, osteoarthritis, and COPD. Not an uncommon kind of person. And she applied all of the disease-based clinical practice guidelines and said, what would this person's day look like? And this is what it looks like. She would take 12 different medications, 19 different doses at 5 different times of the day. And there would be 14 different non-pharmacological things she had to do if she strictly followed those clinical practice guidelines. So again, it's just sort of an illustration of how we have to think more broadly. We can't just think about the silo of the diseases that we treat. We need to think about these patients holistically and recognizing that this isn't possible for just about anybody to do. All right, so let's get back to the age-friendly health system. So this just shows you all of the places across the country that have at some level of participation in the age-friendly health system. There are over 5,000 health systems and hospitals that are participating at some level. And this is what San Francisco looks like. So there's a fair amount going on here in San Francisco. The ones out on the far right, or on the far left rather, is the VA, and then we have here what's going on at UCSF. And I want to drill down a little bit more. This next slide is courtesy of my colleague, Stephanie Rogers, who many of you know leads our clinical programs in our division and has really been, along with many people maybe in this room, but throughout the health system, really helped to spearhead our journey toward becoming an age-friendly health system. And there are lots of things going on here, from hospital care, education and research, community partnerships, and certainly our home and community-based care. But I want to focus a little more directly on our primary and specialty practices. And I want to highlight 2 particular programs, one our Heme BMT clinic and a program that's being developed with radiation oncology. When we talk about programs, we're really talking about people. And so I want to highlight some people who are doing this work. So the first program is our Heme BMT top program, which is a treatment optimization program. Actually, Leah Witt was our very first geriatrician who was involved in this program. And it was really I think the brainchild of Rebecca Olin in hematology, who was an interest in doing research in older adults with hematologic malignancies. And she reached out to geriatrics and said, hey, can we do something in partnership? And so I think this probably started pre-pandemic, and is now her partner in this is Dr. Anu Madhavan, who is one of our faculty, who is doing this work along with one of our T32 fellows. And what they've done is they've created an embedded sort of geriatrics practice where she sees patients roughly half a day a week, sees 4 new patients a week or a couple of follow-ups, and does a 1-hour comprehensive geriatric assessment, focusing on things like bone health, physical function. She does a cognitive screen. And then she takes those recommendations and works with a transplant coordinator to implement the recommendations. They're not currently making decisions about whether or not folks should or should not get a bone marrow transplant, but they're using this information, whether it's for prehab to help people get ready for the bone marrow transplant, or to at least be aware of the potential complications that could occur as a result of these procedures. And the key is this is being supported by hematology. So Dr. Madhavan's FTE is being supported by Rebecca's program. The second one is radiation oncology, and this is where Dr. Catherine Park, who is the chief of radiation oncology, also approached our division chief, Louise Walter, and said she was interested in creating a program in radiation oncology. And this was still sort of in the developmental phase, but her partner in this is Dr. Ashley Manchana, also one of our faculty. And what they've been doing over the last year was a needs assessment. Dr. Manchana has been doing lectures with their staff and faculty around the 4 M's, and they plan to initiate an embedded geriatrics practice, very much like the one in Heme BMT, beginning next fiscal year. So lots going on. There's much more I'd like to highlight, but I just want to give you an idea of the kinds of things we're partnering is going on. So a question that all of you should be asking is, does this approach improve care? And what I would tell you is we have lots and lots of good evidence of inpatient geriatrics co-management. The outpatient evidence base is still developing. I'm going to share a couple of pieces of data with you. So orthopedic geriatric co-management has been around for probably 25 to 30 years. One of my very first role positions I had was working in a geriatrics co-management program. And one of the things I just share with you is what you learn when you start doing this is both of you speak completely different languages. And so much of the early part is learning each other's language. And what I loved about this was I became much better at understanding the issues around the care of any adult with a hip fracture, and understanding what an ORIF meant or hemiarthroplasty, all terms that were completely foreign to me. And for them, it was learning what's an ADL, what's an IADL, how do I understand and recognize cognitive impairment or delirium. But we know from these programs now that they reduce both inpatient and rehab and long-term mortality. They reduce lengths of stay in inpatient and rehab. They improve physical function. And from a process point of view, you're much more likely to have osteoporosis treatment started if you're being seen in one of these programs. In contrast, and I pick this particular slide, one, because it's an RCT, but also it relates directly to one of the programs here. This is embedded geriatrics consultation for hematologic malignancies. And this was an RCT. Patients were followed for over a year. These were 75-year-olds at Dana-Farber who had hematologic malignancies and were being considered for bone marrow transplant. And they either got standard care or they got standard care plus a geriatric consultation. And these data don't really surprise me. There was no difference in mortality. There was a trend, but not a significant change in the use of unplanned care. But you were 3 more times more likely to have a goals of care discussion. And this was valued by oncologists. Now, what does that value mean? Hard to know. But one of the things I think we have to think about if you're designing these kinds of programs is, what are the outcomes that matter to patients? Now, I would certainly not argue that mortality is not something that patients care about. They clearly do. But other things that might be important is, the not utilizing unnecessary medication, or how are they doing functionally at the end of that year? So we need to think about the right outcomes when we think about these kinds of data. All right. And this is really my transition slide to turn things over to Leah. This is Dr. Stacy Hahn, one of our new faculty, doing a house call to one of our care at home patients. Leah.
Thank you, Mike. So I am a geriatrician pulmonologist, as Bob mentioned. Usually pulmonology is combined with critical care. I like to call geriatrics outpatient critical care. I think a lot of you who practice primary care, hospital medicine also do some outpatient or inpatient critical care, even on the wards. And I want to convince you that geriatrics is as exciting and as complex as inpatient critical care, and that you can apply it to your specialty, no matter what that specialty is. So I'd like to start with a quote from an expert geriatrician at Yale University named Mary Tonetti. And she says the time has come to abandon disease as the focus of medical care. The changed spectrum of health, the complex interplay of biological and non-biological factors, the aging population, and the inter-individual variability in health priorities render medical care that is centered on the diagnosis and treatment of individual disease as at best out of date and at worst harmful. The message that Mike and I are trying to leave you with today, and we hope we convince you, is that geriatricized subspecialists and health systems are really the key to high quality care for older adults. And he explained what geriatricized means. Sounds like jazzercised. It really is an exercise. It's a practice that you need to put into play with every patient that you see. So I'll use COPD as a case study for how you can apply geriatrics to a chronic disease. But as we're walking through this patient case, think of a chronic disease that you take care of every day. So COPD, it's very common. It's the 6th leading cause of death in the world. It's fallen a little bit after COVID, but it's 4th in the world, 5th leading cause of disability. About a 12% prevalence in people over age 75. And it's estimated that by 2030, over half of people with COPD will be over 75 years. The case I'd like to present today is someone I'm calling Mrs. Lopez. She's a 76-year-old woman with severe COPD. She presents with her daughter for a post-discharge visit. She's had many ER visits, 2 hospitalizations in the last year. She's got severe obstruction. Her forced expiratory volume in 1 second is 0.9 liters. She has severe hypoxemia. She desaturates to 88% on room air at rest. So she certainly qualifies for oxygen, and she was prescribed that in the hospital. She's very dyspneic, so short of breath that she is short of breath when she's dressing. And like many adults in San Francisco, she's functionally homebound because she lives in a 3rd floor walk-up apartment. So she is very difficult for her to leave her apartment, and she uses a cane to ambulate. So traditional medical management that we are all taught in our medical school residency fellowships is that we, of course, need to correctly diagnose. Just a 1-minute update that the GOLD guidelines have slightly changed, and now we classify people as high exacerbators or low. So you stage the COPD, you optimize her inhalers and oxygen, you immunize her, make sure she's not smoking anymore, refer to pulmonary rehab. And this is not bad, this is great, but this is definitely not enough. And I'm going to walk through each of the M's that Mike outlined and to show how you can optimize and make your management even more age-friendly. So her concern, she's really short of breath. How can you help? Her daughter has slightly different concerns. My mom has a lot of medical problems, a lot of specialists, many medications. She doesn't remember to take her medications. She doesn't wear her oxygen because she's afraid she'll fall because she has to use a cane. So the question I have for you as you're thinking about her care is, how do you consider COPD in the context of her overall health? And what do we need to know to guide treatment decisions? And would an age-friendly approach help? I think it will help. So the 4 M's, Mike went through all of these M's, and our extra M is the multi-complexity. We'll go through this. I think geriatrics suffers a little bit from an identity or a branding problem. You know, nobody wants to see somebody whose specialty is older adults because they don't want to admit that they're older. And what is it? You know, we all take care of older people. So what is it that we're doing that's different? This is a little bit of how we address that branding problem and our identity problem. And then here's a few more ideas of how geriatrics is different. And this comes from one of my mentors, in addition to Mike, Carla Parasinotto. So function is paramount. Function is one of the top things we care about. We care about how people are getting dressed, who's managing medications, do you manage your finances or are there errors? All sorts of things, the nitty gritty social life details. Put aside Occam's razor. So the Occam's razor is that the simplest explanation is usually the correct one. That's usually not applicable in geriatrics. There are many medical problems, many medications, and there can be multiple explanations for what's going on. Existing data does not exist. This is hopefully changing with the recognition that older adults need to be enrolled in clinical trials, but still, you'll see that a lot of people are excluded from clinical trials for having multiple medical problems. Multimorbidity is a huge problem when interpreting data, so you need to keep that in mind. Understand patient context, and then this is yet another way that geriatrics is outpatient critical care. It really overlaps with ICU care. It's interprofessional, it's interdisciplinary, and it cannot be performed just by a physician alone. So our first M is multi-complexity or multimorbidity. I'm going to give you data, and then I'm going to give you what you can do for Mrs. Lopez. So unsurprisingly, people with COPD have 2 or more comorbidities compared to those without COPD. And it occurs at a younger age in COPD. So someone, Mike talked about the age of 65 as being sort of a cutoff for geriatrics. Really, people who are in their 40s and 50s who have COPD are facing some of these geriatric issues that we are going to talk about. Unsurprisingly, more comorbidities equals more mortality. And as I said, many clinical trials exclude people with multimorbidity. So how does this apply to our patient, Mrs. Lopez? An age-friendly approach would be to ban the organ or specialty silos. Consider each medical problem in concert with all of the other medical problems and other subspecialists. I think we do this pretty well at UCSF because our communication and our integrated EHR makes communication a little bit easier. But it's really critical to pay attention to the limits of the clinical practice guidelines. And that Boyd paper that Mike referenced is such an important paper. Does this really apply to my patient? Do I think that this person could handle every recommendation that I'm giving them? Does it make sense to deliver this in one piece or sort of piecemeal over the course of the next several visits? Time management, perfect management. As I said, this is also the Boyd paper, is really unrealistic given time pressures and patient priorities. So look at the big picture, prioritize, and keep reprioritizing. And then care coordination. Of course, communication is really critical. More specialists equal more tasks and more medications. I'll show you some data about that in a few minutes. A unified vision of care is the goal. Doesn't always happen, but communication between specialists and primary care doctors is really important. Our next M, I think this is my favorite M, is medications. There's so much within medication problems, especially cost. So inhalers are some of the costliest medications on a formulary list, and cost-related non-adherence is very high, about 31%, and cost over $20 a month increases risk. And we all know the problems. I'm talking about patients who are typically using Medicare Part D as their coverage plan. And there have been some changes in recent years to Medicare Part D that have made things a little bit more affordable. This year, there's a $2,000 cap of out-of-pocket costs, but in past years, people were dipping into a donut hole and out of a donut hole, and very incomprehensible what somebody's costs would be. Older adults have a high rate of incorrect inhaler technique. And the reasons there might be inhaler technique problems include dexterity, like osteoarthritis or post-stroke, vision issues, coordination, like for somebody who has cognitive impairment, inadequate breath hold, if someone has severe lung disease, and then older adults might experience more adverse side effects. And then polypharmacy, this is work that I did in a community dwelling sample of older adults. We found that polypharmacy is much more common in people with COPD, and they're more often co-prescribed high-risk medications. I think probably because they have more comorbidities and more specialists. And what do we love to do? Add another medication. So that, I think, more specialists may equal more risk for polypharmacy, though I can never find data to support that. So what can we do for Mrs. Lopez? Become a Medicare Part D hero. I know it's dry, might be hard to understand, but I promise you this is one piece of policy that will really take you far in your medical practice. There's a really great website called Medicare Plan Compare. If you have family members who are on Medicare Part D, take it for a spin. You can plug in their medications and see all of the Part D plans and see which one would be most cost effective. Open enrollment happens in the fall. At UCSF, we have had the pharmacy department has had clinics where patients can sign up to meet with a pharmacy student. We'll do this with them and save them thousands of dollars. You probably don't have time to do this with every patient, though I love to share this with patients. But most counties have a program called HICAP, Health Insurance Counseling and Advocacy Program, I believe is what it stands for. You can refer them and they can meet with a counselor to go over their plan and then remind them, don't miss the window for open enrollment. So you can save your patients a ton of money, learn device technique and teach it. So I also like to share this vulnerable fact, which is that when I was a pulmonary fellow and I prescribed Spiriva, tiotropium, a patient asked me, okay, great, so how do you use it? And I was like, I don't know. I just prescribe. I have no idea. So there are lots of resources for you to learn how to use inhalers. YouTube, the COPD Foundation has created great YouTube videos for inhaler teaching. And because there are so many devices, there are new devices, soft mist inhalers, dry powder inhalers, they're always changing. It's really a good use of your time for 2 minutes in a clinic visit to watch it together, have them come back and you can watch their technique. Of course, you should encourage them to meet with their pharmacist, their retail pharmacist, but there's the patients often rely on you in your clinic visit to teach them technique. So highly recommend that. If inhaler technique cannot be perfected, that's when you switch to nebs. Nebs and inhalers are very equivalent, but if somebody has cognitive impairment and cannot be taught how to use an inhaler, that almost every medication can be switched to a neb. And the COPD Foundation app is a great resource for that. And then combat polypharmacy. It is an instinct when you meet with somebody to want to do, but if it's not necessary, consider holding yourself back. Think about combination medications. If there are high-risk medications, you can see that their primary care doctor has been working with them to get off zolpidem. You can be another voice. So think about how medications interact and how you might subtract a medication. Our next M is mobility. And this, I think, is best characterized by frailty and function. Frailty is sort of a buzzy, hot term in subspecialties. Frailty is sort of like when you see it, though we have great frailty criteria that we use. Probably most famously is the Fried frailty criteria. Some of the criteria are hand grip strength, how much activity people are doing, lots of different things. Rarely you're calculating it in clinical practice, but it's a multi-system condition. Frailty prevalence is about up to 25% in those with COPD, and it's about 15% in the general population. So people with COPD are definitely more frail, and it's associated with worse outcomes, adherence to rehab, hospitalization, mortality. And then in work I've done, I found that people with COPD have really high rates of ADL disability in a nationally representative sample of people living at home. These are not people that are hospitalized or in a nursing home. So what can we do for our patient? Refer her to pulmonary rehab. This graph shows that there is no age limit to who benefits from pulmonary rehab. Even people over 80 have a significant benefit to pulmonary rehab. It lowers the risk of death. There was a study a couple of years ago that showed that Medicare beneficiaries who were hospitalized for a COPD exacerbation, and they started pulmonary rehab within 90 days, had a lower risk of death in the following year, and there was a dose effect. The more pulmonary rehab sessions they got, the lower the risk of death. There are not many medications that can do that. So pulmonary rehab, unfortunately, is such an important treatment, but a very limited resource. And even in a city like San Francisco, there are not that many options. We're lucky enough to have a program here. So, the emergence of pulmonary rehab programs is an option for people who live in lower resource settings, and that's something that's continuing to be developed. Number 2 is reduced disability. So disability is the distance between someone's capabilities and their environment. So if you can reduce that distance, your patient is able to live, hopefully, a more social life. They're able to get out of their house. That means a DMV disability placard. I'm always bringing it up. shower chair, grab bars. You might feel like that's really out of your wheelhouse. It is something that you can refer people to physical therapy or home physical therapy if they qualify for it, to get an assessment. And I think you can also take a look at some professional societies have statements on treating frailty in adults with chronic lung disease. The European Respiratory Society is one example. And then finally, beware of oxygen overprescribing. This is a bit controversial. In her case, she has severe hypoxemia. She certainly qualifies for oxygen as a mortality benefit. But for people where it's a bit more, we're a bit more unsure of if there is actually data to support oxygen use, mortality benefit. These are people who are desaturating when they're ambulating, not at rest, but desaturating when they're ambulating. The data is much more mixed. And I think it's really important that you have a risk-benefit conversation with the patient. In her case, if she's falling, she's not going to leave the house with her oxygen. And if the mortality benefit was really unclear, you might stop yourself from prescribing oxygen. There's been some great work done here at UCSF by Angela Suin and her colleagues who showed that oxygen prescription increases the risk of self-reported loneliness because they're more socially isolated, harder to leave the house. The next M is mentation. So cognitive impairment is certainly more common in people who have COPD. The prevalence is about 32%, particularly among those who are hypoxemic, which makes sense. And there's shared risk factors. Tobacco use and pollution are shared risk factors for cognitive impairment. And it definitely impacts their activities of daily living. It increases hospitalizations and length of stay. The other element to the M of mentation is social frailty symptoms, social isolation and loneliness, and mood symptoms like depression and anxiety. So the work by Angela Suin and colleagues that I've referenced, she showed that 1 in 6 people with COPD feel socially isolated, and 1 in 5 people have loneliness. And then in work I've done, I've also showed that people with community dwelling, people with COPD have more extreme social disengagement, loneliness, and even less sexual activity in the last year. And these are people who are living in the community. Social isolation and loneliness also predict hospital admissions in those with respiratory disease. So what can we do for her? We should be alert for cognitive impairment. And Mike mentioned this, your patient may see you, if you're a subspecialist, more than their primary care doctor. So you may be the one who's picking up on cognitive impairment. You should seek collateral history. That's where a caregiver or family member can be helpful. Subtly investigate. That's why I sometimes like to do my own medication reconciliation. Some of that could be cognition, some could be medical literacy. And then maybe even do a mini cog. It only takes 3 minutes. This is asking a patient to remember 3 words. I always use tree ball flags so I don't forget them myself. And then draw a clock. These are some clock examples. I do this all the time when I was in the top clinic, the Heme BMT clinic, on Zoom. These are easy to do on Zoom. These are incorrect clocks. I also always give them the same time of 10 past 11. And then distract them, do a little social history, a little chatting for 3 minutes, and then ask for the word recall. You can chart this in Apex in our age-friendly tab. So if you pick up an abnormal mini cog, that would be an alert for you to contact their primary care doctor and think about next steps for working up. Obviously, this is just a screening test. Screening for mood disorders, they certainly impact disease management. And then social connection is key. It is really a part of medical management. That would involve referring to local senior centers. We have a ton in San Francisco. We're really lucky to have those. Encourage people to leave their house. Encourage them to travel if you feel like it's medically safe to do so. Travel is an aspiration for many older adults. And if you can be another voice to say, why don't you try it? Let's try to make this safe, then they're more likely to do it. The final M that we'll review is what matters. So symptom burden for people with COPD, it's usually cough and dyspnea, and can be multifaceted. There's the physical component, there's social aspect, the spiritual aspect, psychological, and many of these elements are often not managed adequately with our traditional Western medical tools like inhalers. So you should think, we'll talk about a little bit more what to do next, but thinking about referring to palliative care and what other resources you could look into. Like, for example, the American Thoracic Society has a acute breathlessness attack resource for patients. More work by Angela Sewin and colleagues, she showed that people with chronic respiratory disease, COPD and IPF, are much less likely to receive outpatient palliative care and opioid prescriptions than those with lung cancer. I think it's become sort of second nature for us to think about palliative care for people who have cancer, and especially lung cancer, but less so with other chronic diseases. And those with COPD are more likely to use end-of-life intensive care than patients with lung cancer. So for Mrs. Lopez, what can you do? Deliver a diagnosis or prognosis with expertise. These conversations are often bad news conversations. Spikes, it's hard for me to keep a lot of mnemonics in my brain, but spikes is a good one. It's a useful strategy for a patient or family meeting. Setting, think about the environment, perception, ask the patient and family what they know before you tell them. Invitation, ask for an invitation, invite them, ask them if they are okay with you sharing the information, share knowledge, address emotions, and then summarize and strategize. You can seek additional training and communication with difficult conversations with many resources. We have a lot here. Vital Talk is another great resource. Ask about symptoms, refer to palliative care for symptom burden, coping strategies, future planning, and plan for the future. So for Mrs. Lopez, she was just discharged from the hospital. That's a great time, kind of a spark for the conversation to talk about how the hospitalization went and a plan for the future. You can review what's going well, what did she feel like went well during the hospitalization? Is there something that she doesn't want to do again? She wouldn't want to go back to the ICU, for example, and make a plan from there. So for Mrs. Lopez, instead of our one-liner being, she's a 76-year-old woman, recently discharged from the hospital with COPD, will optimize her inhaler regimen and refer to pulmonary rehab. You are geriatricized. So you say that she's a 76-year-old woman living independently with mild cognitive impairment and mild gait instability. She uses a cane to walk with significant functional impairment related to chronic lung disease. You have to assess her ability to use her inhalers, their cost, if mobility issues are impacting oxygen use, her understanding of prognosis, and the impact of cognitive impairment, and wishes for the future, in addition to optimizing her inhalers and referring to pulmonary rehab. So the call to action that Mike and I want to leave you with is to become geriatricized. I recommend that you look into joining an aging interest group in your professional society. We have one at the American Thoracic Society, both initially started in critical care, and we've developed one for outpatient pulmonary medicine. Partner, and I know many other subspecialties have similar aging groups. Partner with geriatricians, or even do a clinical geriatrics fellowship. It's only 1 year. I did it. You can do it. Geriatric, and don't forget about geriatrics principles. Function is paramount. Forget Occam's razor. Use the 5 M's in your routine subspecialty practice, and take a multi-pronged beyond the specialty organ approach. I want to leave you with a few resources. I'm a producer for the Curbsiders Internal Medicine podcast, and some of what I presented today, we've also presented in a few episodes that we've produced, COPD in older adults and outpatient oxygen. So take a look if you're interested, and thank you so much. We'll open it up for questions. Thank you.
Thank you so much. Tell me we've been working on this age-friendly emergency department for a while. What do you think is different today if I came into the ER than it would have been before we did that? What do you think actually happens in these practices as we do an age-friendly intervention?
So I can tell you one thing I know specifically happens because I've seen it in my patients. So I have, as Bob mentioned earlier, my clinical practice is in our care at home program. And so while we've shown that we can reduce utilization, some of our folks do end up in the emergency department. And often what times is I will get, after a person's been in the hospital or in the emergency department, I will get a note. Often it comes from a pharmacist who's identified potentially high-risk medications that my patient has gotten with specific interventions or things that I can do to potentially deprescribe. So those are some of the things that I specifically can say happen. Beyond that, I don't know that I have a lot more personal experience.
Yeah, no, I think it's they do a great job screening, similar to the acute care of the elderly service, which will see patients who are on a certain unit or above a certain age. And I've seen discharges from, notes from those patients. They'll do mini cogs. Did you know your patient had cognitive impairment? I know I'm a geriatrician, but a lot of times they'll be like, oh yeah, no, I didn't. So I think they do a really great job of picking up things that kind of go under the radar in the outpatient setting.
Great. The Boyd study is striking. I remember seeing it as well and was flabbergasted by it. What's your reaction to it? I mean, obviously we have to prioritize it's impossible. You can't do all that. No patient can do all that. And yet all of those interventions make sense through the lens of each one of their diseases. So how do you get from there to a practical approach of what the patient actually gets prescribed or what the patient can actually handle?
I think this is where we need to incentivize becoming a primary care doctor as much as, an outpatient critical care doctor as much as becoming an inpatient one, because the guidance from a primary care doctor is really paramount. They are ideally the person that's helping synthesize goals in prioritizing health conditions. Absent primary, many people do not have a primary care doctor and they are seeing multiple specialists and having to sort of synthesize things for themselves. And hopefully that's where the specialists will start to interact and talk and become interested in an age-friendly approach. But that's where a lot of it is on the patient's shoulders to prioritize. I really think it's all about an investment in primary care.
Mm-hmm.
I would just add the other thing I think to sort of also guard against is not making these decisions just because of age alone. Right? I think the potential is for the bias to be, because you're at this particular age, we should no longer consider this particular approach or intervention. There's certainly things where that does make sense. There's plenty of evidence for things like cancer screening, for example, at above a certain age, that the burden is much more likely to experience the burden of the intervention than the benefits. But what I've always taken away from that paper is not so much the idea that anybody is going to follow any one of those single clinical practice guidelines. It's the idea that get out of that thinking of, I'm a rheumatologist, my patients just have rheumatoid arthritis or lupus, and so I only have to think about lupus. You have to think about them in the context. So for me, it's really the illustration of the failings of that sort of clinical guideline approach.
Yeah. It also seems that there's some data visualization that's really important here, because I think for each of the specialists, they may not understand that the other specialists have recommended all these other things, and that the totality is ludicrous.
Right.
And yet, a primary care doctor or geriatrician theoretically would be able to do that, and yet there are not enough, and they don't have the time.
And I would say that, and this is arguing against my profession. These are not things that it takes extra special training to get. It's really just sort of being able to step back and think, asking some of these questions like, where do you live? What's your living situation? I think you prescribe someone or someone has to get treatment that requires them making multiple visits. Is that really realistic? Is there some other way? Or because we're not going to do that, is there another approach that we can take? If you're not asking those questions, then it becomes hard to know how to make those decisions.
Let's open it up. Anybody has questions? Yeah.
It's sort of thinking of this in an extra medical way, like thinking of scalability. Are there policy options that can be pursued at a society level to encourage more folks to go into geriatrics? Because at the end of the day, we're all patients, and seeing those data points was quite a. So I'm just interested in the policy options.
So Mike has been a leader in the American Geriatric Society, as I'm sure thought a lot about policy options, try to increase the geriatrics pipeline.
So I would say this, we are one of the, I don't know if you even read just the popular literature, we're one of the few fields that talks about all of our warts. We talk about how there's not enough of us. We talk about the relative discrepancies in pay compared to other professions. None of us are starving in geriatrics, I promise you. And yet we don't talk about the fact that when you look at lists of satisfaction in terms of practice, geriatricians often rank very among the highest in terms of satisfaction. As Leah said, we've always had this sort of branding issue. And we've compared ourselves to palliative care. Palliative care deals with the death and dying, and yet it's a highly popular practice. There's something about this idea. I didn't think about it goes back to ageism. It's one of the sort of last sort of prejudices that's sort of culturally acceptable. You can still make jokes about old people. You're not gonna get canceled for making a joke about an old person. So there is policy-wise, yeah, I mean, there are things like loan forgiveness programs, there are lots of things, but they have not really sort of still spurred people. I think it has to do with figuring out ways to find people much more early in the process than before they get to residency or even medical school.
Yeah, and Mike and I were talking before, in the UK, the geriatrics is the most popular specialty off internal medicine. Some of that has to do with the less of a pay differential there than there is here, but it's also emphasized from a policy standpoint. Allison.
Great. Yeah, that was so interesting and so helpful. And I think as an ID clinician really called to mind what HIV clinics look like now. Now we're super lucky. A lot of our patients with HIV are virally suppressed, and now their primary issues are cardiovascular disease and things like that. So is sort of echoing the model that you all are talking about, which is great. I had a question from the audience from Dr. Adler-Milstein, sort of related to the other question, taking a systems level approach. But this question specifically is like how to move the needle to take the burden off the individual clinician when we're talking about address this, address that in clinic, and keeping in mind clinicians are stretched thin, and even with the best of intentions can be challenging to do that. So I'm curious if you all have thoughts related to that.
Yeah, I think you have. Thank you. Yeah, I think it is about pacing yourself. You cannot tackle everything in one visit. And I know bringing back people back for visits every 2 or 3 months is really not feasible, but you do have to pace yourself and prioritize, as I said, and then reprioritize and try to identify the sort of highest risk issues. I do think cognitive impairment is maybe at the top of the issues that goes really under-recognized and can impact a lot of treatment. So even if you pick up on cognitive impairment or you help deprescribe a high-risk medication, I think that's a huge win. And then communication, we're all playing sort of a long game with a lot of teammates, maybe even not in our same health system, but if you can help sort of pass the baton to the next physician that's taking care of them and say, this is what I'm worried about, this is what we talked about, that can be a way to stretch what you're trying to do in your clinic.
And I would add, the point you're right is that this cannot just be one person in a clinic. You have to be able to build your staff to think about these things. Ann Suskin, who's one of our urologists here and was one of the GEM stars, in her practice, before she sees a patient, her staff do a time get up and go test. And she uses that, I think, in terms of thinking about weighing risks and benefits of potential surgical interventions, for example. So that's not something she's doing, but her staff now does that. So it's working with your staff, helping to understand. I hate the word train, but teaching them to use some of these interventions. They can learn how to do a mini cog before you see the patient, for example, or an SF9, a PHQ-9, for example. There are things that if you're seeing that are kind of prevalent in your practice, you can build them in so that other members of your team can do some of these screening tests.
Right. Time for one more. Yeah.
With particular challenges with tech, with Zoom visits and those kind of things, and do you have any solutions or ideas that can help with our patients?
Question is what you're noticing now that more Zoom visits are remote or virtual?
Yes. So I'm the ambulatory chief in pulmonary, and I've helped build our referral triage, and I prefer to see the older the better is my tagline. So I prefer to see people that are older. And in the last week, I had several no-shows, and I noticed the age of the no-shows was over 80. So I think part of the issue that we're facing is that a lot of the appointment reminders, for example, are on text and email. We were just talking about that in our management meeting today. How can we reach out to patients who might not be tech savvy? Zoom, I would say less. I mean, that certainly was a growing pain during the pandemic, but it seems like a lot of people have figured out how to either use Zoom or have had a lot of neighbors come over and help get onto Zoom. But I do think there still remain a lot of tech issues. And
Have you sort of developed a bias, or all else being equal, do you prefer, and do you find an 80-year-old prefers doing it virtually or coming in, or totally individual?
Yeah, interesting. I do think people are really hungry for in-person visits, but we're in such a unique geographic situation where we're seeing people who live 4 hours away. So that will sometimes bias them to wanting to do a virtual visit. But all things being equal, I think patients would like to be seen in person more.
And maybe one last quick question. You didn't mention spacers when you were talking about the inhalers. I assume they are good and that some of the people who struggle with
Yes.
inhalers, that helps?
Yes, spacers should be used if they are using a meter dose inhaler, but you can't use those with a dry powder inhaler or soft mist inhaler. There are also devices, that podcast episode that I mentioned that I did with Amber Lene Amartya-Rossoff at she's at Wayne State. They, in their clinic, they use devices to measure inspiratory capacity to see can they actually deliver the device appropriately. So there's a lot of things you can do, but definitely spacers require less of a forceful inhalation.
Great. Thank you both. It was terrific and really useful and important. Thanks.
Yeah.